first introductory slide. خليها أعملها full screen. I'll make it a full screen. طيب. So the title of the talk is Overview of Common Endocrine Disorders. Okay. طيب, this is our hospital. طبعا اللي هي King Abdullah Specialized Children Hospital. Is very big hospital in the Middle East. ويعني it includes all the subspecialty of pediatrics. طيب, the endocrine glands يعني احنا if we start from خلينا اشيل دي بس بعيد شويه كده. How can I take this from the way? Good. طيب, good. الآن we have the pineal gland. طبعا the main endocrine glands are the pituitary, guys, and also called hypophysis. Okay, so that's why you hear sometimes adenohypophysis. That means the anterior pituitary, and the neurohypophysis is the posterior pituitary, and it's called like this because the embryological origin is different. So the neurohypophysis is coming from the nervous system, adeno from the base of oropharynx. Then we have the thyroid gland, and we have the parathyroid glands, 4 of them at the back of the thyroid gland. And we have the thymus. It also has got, like the pineal gland, has got some endocrine function. Again, it's not one of the main. The main are pituitary, thyroid, parathyroid, adrenal, sex organs, and the pancreatic cells. The pancreatic islets or gland. So, and here this is the endocrine part of the pancreas, and there is exocrine part of the pancreas. And we have the adrenals on the top of the kidneys, and we have the ovaries or testes. There are 3 levels of control, or we call them axes. So the plural of axis. And the first level, which is a tertiary level, is at the level of the brain. The hypothalamus has got control on the pituitary gland, anterior and posterior. And then the pituitary gland is called the master gland, which send messages to other glands in the body. And these glands are the thyroid, the adrenal gland, the different tissues that respond to growth, and then the sex organs. And then we have the breast tissue, the prolactin, and then we have the posterior pituitary has got hormones that works on the kidney and also on the muscles of the uterus and muscles of lactation in the breast. So we have the TSH, and above that we have TRH, and ACTH, we have above that CRH, and then we have the growth hormone, and above that we have the growth hormone releasing hormone, and then we have the gonadotrophins, and then we have on top of that gonadotrophin releasing hormones, and we have the prolactin, and before that we have the prolactin inhibitory factor and prolactin stimulatory factor, and we have the ADH primarily produced in the hypothalamus, and also the oxytocin, and is stored in the posterior pituitary, then secreted and in the appropriate times to control water homeostasis, or during pregnancy and during delivery or time of lactation. So the anterior pituitary secretes 6 hormones coming from 5 cells. The first is the thyrotrophs that secretes TSH, that stimulates thyroid to secrete thyroid hormone, T4, which change in the tissue to T3 as well, T4 and T3. And then the corticotrophs that secretes ACTH, that stimulates the adrenal cortex to secrete cortisol, while the aldosterone from the cortex is under the control by the renin-aldosterone system, juxtaglomerular apparatus in the kidney. And then we have the growth hormone, is a hormone directly secreted from the anterior pituitary from the somatotrophs. That's why it's called somatostatin as well. And that helps the growth of the tissues, especially the long bones, linear bones. And then we have the gonadotrophins. These are LH, FSH, and these are secreted from gonadotrophs. That's why we have 5 cells and 6 hormones. So the autotrophs, there is acidophilic and basophilic secretes the LH and FSH. And then we have the lactotrophs that secretes the prolactin. Okay? Right, so the hormone receptors can be, the hormonal action mimic someone shooting a shoot to a target. So the shoot is the hormone, and the shooter is the gland, and the target are the target organs. And when the hormone reaches the target organs, obviously it gets attached to specific receptors, and then you have post-receptor signal transduction. So all the endocrinopathies are either high or low. And this low can be a true low in the secretion of hormones, or can be a pseudo low. So you have pseudo hypoaldosteronism, pseudo hypothyroidism, and pseudo hypoparathyroidism, etc. And the pseudo means that there is a problem in the receptor at the receptor level. So you have excess of the hormone, but it's not functioning. So in the high we find high hormones, in the low we find low hormones, and in the pseudo or relative low we find that the real hormone or the hormone trying to stimulate the target organ is actually in excess but unable to work. And the problems, the hormonal problems, can be secretory problems from the gland, or can be at the receptor level, as we just seen in the previous slide. We have the shoot and the shooter and the target. So if you have a problem at the receptor level, then you have resistance. And if you have secretory problems, then you have deficiency, or you have secretory problem in excess. So you have hyper condition of the endocrinopathy. And these problems can be congenital or acquired. So you can have congenital growth hormone deficiency, or you have acquired growth hormone deficiency secondary to road traffic accidents, for example, or brain tumors. And most of the pediatric diseases now have genetic and immunity relationships. So they have some immunological background or genetic background or predisposition. So the main topics in endocrinology are growth, puberty, diabetes, obesity, hypoglycemia, hypopituitarism, thyroid, adrenal, disorders of sex development, calcium and bone metabolism. Dyslipidemia is actually a metabolic topic. I'm not quite sure whether you're covering the metabolic with Dr. Serrar or not. Like it depends on the area, whether it's tackled by the endocrinologist or the metabolist, but it's basically an enzyme-based science more than hormonal related, and therefore historically they are not part of the endocrine disorders. But I just added them here in case you are not covering them. It's one of the important topics you need to cover in your pediatric revision. So you need to know about primary and secondary dyslipidemias, and the subtypes of primary dyslipidemia and the different causes of secondary dyslipidemia. What I'm going to cover today are the growth, the puberty. I will touch base on the diabetes, maybe the DKA if I find a chance. This is a different talk. I'm not going to talk about obesity. Hypoglycemia will be covered by Dr. Bashir Al-Wasila next Thursday. And hypopit is something we are going to touch base on, because if we talk about growth and puberty and thyroid and adrenals, we are more than halfway of talking about this, because we will talk about this at primary and secondary level. So by definition, we are talking about isolated deficiencies in these topics, and also the secondary include the secondary level of deficiency includes hypopituitarism. Disorders of sex development is a subcategory from the adrenal problems, but it can also result. It can result also from other pathogenesis, which we'll talk about. But the commonest type of DSD is congenital adrenal hyperplasia, which is belonging to the adrenal problems, and calcium. So I'll talk about DSD, calcium, adrenal, thyroid, and puberty and growth. And if I find the time, I'll talk about diabetes, and I'll leave the rest of the topics to be covered either during the MCQ sessions or separate talks by my colleagues next week. My talks here will be simple, contains a lot of photos and explanation and description of the pathogenesis and management, and also will include some MCQs at the end of each section, possibly, or most of them. Yes, Samar, عندك سؤال, you raised your hand. تفضلي. You raised your hand يا دكتور سمر. Share via YouTube. I'm not quite sure how to share this via YouTube, but anyway. Samar raised her hand. Do you have a question, or are you able to open your microphone? طيب. If you are able, interrupt me. Huh? And I will just carry on with my slides. طيب. Okay. طيب, let us start with the growth and puberty disorders. طيب, خلينا نشوف الكويشن عن مين اللي عنده رابط اليوتيوب لو ممكن. بكلها يعني connection. I don't have nothing to do with that. Maybe Dr. Mohammed Zain can deal with that. We don't have microphone. So do I need to open them? Open the microphone يا دكتور محمد. هل أنت معانا ما زلت؟ محمد الزين؟
أيوة دكتور أمير, I will open for you المايك للناس اللي بيرفعوا يدهم if they want to
أيوة.
answer.
كويس.
Okay.
في الآن واحد اسمه سمر ما أعرف قالت شوف whoever raise يعني تابع لو في حد raised her or his hand. كويس.
أيوة.
want to interrupt with the question خليهم أديهم فرصة طوالة. I will pause and answer the question.
Okay.
ممتاز. يلا we'll carry on. So I'll start now with the growth and puberty disorders. طبعا التوبكس دي طويلة شوية عشان كده أنا هتكلم بسرعة شوية. كويس. If you cannot follow me, برضه this is enough reason to ask me to repeat if you wish. تمام. SMS question and answer. As they said, they will contact me through that. Okay, that's fine. Fair enough. طيب الآن you can see the growth chart on this side, and then you see the axis here. As I mentioned, starting from the even higher than the hypothalamus, there is central nervous system control, and there are some positive or excitatory and negative and inhibitory stimuli to the hypothalamus. Then this is reflected on the anterior pituitary, which send messages to other glands. طيب, if we ask a question, is this girl short? So obviously, we cannot answer this question without knowing how old is she and from which background she is. I mean, in terms of her father and mother height. So we know her family target potentials. So we know the mid-parental height, and then what are her family target potentials. We'll talk about this in a minute. So it's not easy to answer questions sometimes without background information. So it will be a matter of guessing. We'll come back to this scale again later. So that tells us, we have the centiles, and we have to, the best option is to have population-friendly centiles. So if you have these centiles from America, for example, that means you are comparing Sudanese children with American ones. If you use it in Saudi Arabia, the same. If you have Saudi charts, then that's more population-friendly charts. But they can also have some problems if there are some secular trends and changes in the population, and this is not updated. So every now and then, so every, say, 7-10 years, you need to update your growth charts because there is secular trends and changes in the body build of patients in different populations. If we talk about the standard deviation, then obviously more than 2 standard deviations. That's as the bell chart means the patient is outside the normal zone, and so the gross short stage is defined as more than 2 standard or 2.5 in some literature find percentile, 2.5 percentile, 3 third percentile or more than 2 standard deviation below the mean. So this mean needs to be the appropriate mean for this population, for gender as well. So that's why you have boys chart and you have females chart, and chronological age. Okay. So investigation of children less than 2 standard deviation reveals about 15% of pathology. But when the children are very short, less than 3 standard deviation of the mean, this will identify almost 60% of pathological cases. So that means as you go far from the mean point, that will make you more likely to have a pathology. Compare the child's height with the length of the population, as I mentioned. If you don't have a population-friendly chart, then obviously you need to know your population better. So even in for example, in Saudi Arabia, the charts here, there are many hospitals, they don't like to use them because they think they are out of date and needs to be updated. But we know that girls in Saudi Arabia will be within acceptable height by the society if they are not shorter than 150 centimeters, and boys 160 centimeters. These may not be determined the targets in Sudan. So in Sudan, for example, the girls may not be less than 160 or 163 or something, or 5, and the boys will not be shorter than 165 or 170. So I think you need to know your population by experience, and possibly if you contact the team with Professor Ahmed Abdullah, they have their own obviously standards in mind. Dr. Selwa, Dr. Arij, Smahan, where they will tell you and give you a lot of tips, obviously from their building up experience of knowing their patients better than us. And these are the CDC. These are the Child Development Center, or chronic diseases, communicable diseases have these charts in America. These are ones for girls. طيب مين قال chat هنا؟ في حد قال chat. Okay, Dr. Muhammad, we need the minus pediatric there. So these are not belonging to me. Anyway, طيب. So short stage is divided less than 2 standard deviation, the velocity as well. So it's not only a one visit that will tell you that this patient growth is going right or wrong. You need to see the patient for the second time. So a second visit is very important in growth assessment, because you will see how much the child grown in the last, for example, 3 months, 5, 6 months, 1 year. And the growth velocity is measured per year. But even if you see the patient is 6 months and he grew 3 centimeters in 6 months, that means if he follows the same pattern, this patient will grow for 6 centimeters per year. So 6 months appointment will also give you a clue. So this is important, because you may see a patient normal now or within normal, but this patient growth is drifting away, so dropping down. And this happened after an accident or observation by parents, because this patient had road traffic accident or brain tumors or whatever. Height of a child must always be defined in the context of genetic potential. So maybe he's coming with a short family, okay, and they want him to be taller than the average, even in the society. But this has to be taken into consideration. Even in the history, if there are some remote members of the family who are short, this has influence on individual members of the family. Failure to thrive is something different. So many patients come to us as gland doctors because of, sometimes they say he has an enlarged gland, and this is usually confused with hematology oncology. So they mean the lymph nodes. And also they send them over sometimes when they have mixed problem of weight, height, and head circumference. And this is a failure to thrive issue. So the patient may have other hidden pathology and not pure short stature. And this should be tackled in collaboration with other specialists. طيب احنا قلنا I mentioned that, and it's important to know the mother height and the father height. And in the context of that, you decide this child is going the right direction or not. Is he short, going to be short or not? ما أعرف أنا عندي هنا موجودة، شكلها ما موجودة. I need to go back. Sorry. طيب ليش هذا سوري it's not there. So there is a slide, I'm not quite sure it will come later, where you can decide for family target potentials by measuring or calculating the mid-parental height. في واحد فيكم يقدر يقول لي يعني how you calculate the mid-parental height in a very brief way عشان تكون easy شوي يكون interactive السيشن.
الشباب those who are interested they raise their hand عشان نقدر نفتح لهم المايك.
يلا يا شباب ما تتهيبوا عشان انا يعني سبيشاليست في in this subject. Good. في واحد raised hand.
دكتورة تقوى تفضلي دكتورة تقوى.
Okay, السلام عليكم. If the patient I deal with is the male, I will subtract his the height from the father height and add. I will not subtract. I will add the mother and father height and add 6.5. If it is a female, I will subtract the 6.5 from mother and father height.
ممتاز ممتاز. طيب very good. خليكي معايا خليك معايا. هو شوف الآن في طرق كثيرة. أنت ممكن تقول مثلا I will add 13 كويس يعني mother or father height and add 13 to both of them وبعدين divide by 2 كويس. وممكن أنت تعمل الميد بوينت وبعدين you add or deduct 6.5 اللي هو يعني نفسه هي 13. وفي ناس بيقولوا 7.5 عشان تكون 14. It doesn't matter 13 or 14 ولا 6 ولا هي الايديا عشان ما تنسوها دائما انك if you are doing the mid-parental point or height for a boy then you need to make the mother height like a man height. So you add this 13 to the mother height, then you make it like the father and then you get the midpoint. And if you want to make it for a girl, then you deduct the 13 from the father height. So you make his height as a woman height. And then you get the midpoint between the corrected height for the father and the mother one. And by this, you know, this is why called mid-parental point. يعني بتصححوا للفيميلز وبتصححوا للميلز according to the opposite gender of parent. واضحة؟
Yes, clear.
Clear. هذه طريقة سهلة في انك تتذكرها يعني اسهل ما تتذكر رقم. زي ما قلت لك يعني لو انت عملتها from 13 ولا 14 or even 10 الارقام بتجي متقاربة. After you get the point then you add to this 8.5 or 10 برضو. يعني مثلا if you want to be accurate you add and deduct 8.5. لكن if you add 10 it's easy. يعني انا مثلا لو قلت لك mid parental point of this boy or this boy is 150, that means this boy height is acceptable between 140 and 160 in terms of his family. كويس يعني الفاميلي تارجت بوتنشال بتاعته ازيد وانقص ب10 من الميد بيرنتال بوينت. These are the family target potentials. واضح؟ محمد عبدين تفضل. دكتور محمد في محمد عبدين ده رسال سؤال.
تفضل يا محمد المايك از اوبن.
السلام عليكم. ايوه بس انا كان داير اقول نفس النقطه اللي كان اتكلمت عنها دي. الميد بارنتال هايت فور بويز اند جيرلز.
نعم.
يعني corrected mother height plus father height for boys. Corrected mother height, corrected father height plus mother height for girls.
ممتاز. يعني هو ده this is the easiest way to remember it. كويس لأن يعني كده أنت it makes sense إن this is a mid-parental point. Okay. والفاميلي target potentials are around this. However يعني تذكر إنه ده ما the most important in making a decision to give treatment or not. لأنه أصلاً يعني sometimes some children may have influence from remote member of the family. جدته كويس أو خالته أو عماته كويس. فthats not a rule إنه يعني just تحدد الفاميلي تارجت potentials according للfather and mother the father and mother height. Okay. طيب carry on. طيب عندنا برضو الجروس velocity is variable. That's very important. عشان كده في حاجة اسمها gross velocity chart. شوف الجروس velocity الآن وين؟ لا أشوفه هنا ما موجود عندي. في سلايدز ما اعرف موجوده عندي. طيب anyway في الفيرست يير انت بتشوف انه بيكون في، لو عملت فيلوسيتي شارت تلقاه عالي جدا، بعدين بتلقى واحده سمولر شويه، بعدين تلقى ثاني علو اقل من العلو الاول. اكشولي العلو الاول هو ده اللي هو 1 year بيكون في gain of 25 centimeters. طيب وبعده في السكند يير 12 centimeters. في الفيرست 2 years ده this is a big jump in the gross velocity or infantile jump. And then you have the growth rate is 5 to 8. حتى في الثيرد يير هنا كاتبينه انه شويه زايد، لكن بعد كده until puberty بيكون 4 to 8 او 4 to 7 centimeters per year. And then after that you have a growth spurt. الجروث سبيرت اقل من الانفانتايل هايت جين اللي هو كم؟ تكون 8 to 12 centimeters، يعني about 10 centimeter on average. اللي هي بتتاخر في البويز بتكون at around the stage 4 of puberty، وبتكون earlier كويس في الجيرلز، عشان كده the girls end up shorter than boys. So they have the growth spurt later by almost 1.5 to 2 years، وبتكون higher شويه كمان the growth spurt in boys. So that means انه in terms of growth velocity اكبر velocity موجوده وين؟ في الانفانتايل period 1 to 2 years. بعدها في slowing down شويه until puberty، وبعدها عندنا another spurt during puberty اقل من الانفانتايل one. ممتاز. Another very important point، انا ما I will not cover every point mentioned in the slides لانه المعلومات كثيره شويه كويس، اللي هو a change in the standing height كويس، ده هو بسموه height. لكن if you measure someone lying down this is called the length. This is typically done for children up to 2 years of age or children who have disability, and they are measured by infantometer. And we have for the standing height we have a stadiometer, and sometimes if we don't have the stadiometer you can measure them against the wall. Yes, and we have some stadiometers fixed against the wall. This is called these are called wall-mounted stadiometer. Right. So this is telling you the same about growth velocity. However, the control of growth in infancy by nutrition mainly, and then by growth hormone IGF-1 axis. In childhood, growth hormone IGF-1 axis, and then also thyroxine has got a major role. Thyroxine is also important in other parts, but number 2 in childhood period. And then during puberty, the growth hormone IGF-1 axis is the main, with the help of sex steroids, which help the growth of the spine. This is just telling you about the different levels. اللي هو growth hormone is directly working on liver to change or to help it to produce IGF-1 that works in the growth plate, in the receptors in the growth plate. So you have IGF-1 effect and you have growth hormone effect. And you may have in the resistance problems with IGF-1 or problems with growth hormone receptor, these in Laron syndrome and syndromes that in which you don't have good response to growth hormone. So if we talk about the etiological causes of short stature, and the history and examination is guided by this. At postgraduate level, you have to guide the history or history taking and examination by the etiological causes and the pathophysiological causes, because this will tell the examiner that you are asking about specific questions, and it's not just random and routine way of taking history or examining the children without any clear purpose. So the short stature can be non-pathogenic or pathological. So the non-pathological one is the constitutional delay of puberty and the familial or called genetic short stature. And the difference between them, the constitutional اللي هي تركيبي. It means that this person has got a delay تركيبي في جسمه في growth and puberty, but they catch up at certain point. This constitutional delay can be isolated in growth only or can be in puberty only, but commonly they are together, constitutional delay in growth and puberty. So the commonest cause of short stature in boys, almost 90% of short stature in boys is due to constitutional delay and of growth and puberty. If you see a short girl, pronouncedly short, then obviously you have to think about Turner and the karyotype and whatever. So you have to look actively for a cause, not like in boys. Familial short stature is a genetic one when both parents and number of family members are short. So there are some genetics of short stature, and this is mainly in the gross plate side, not at the growth hormone secretion level. Skeletal dysplasia, so this is also bony problems. So this is one of the pathological. Intrauterine growth restriction or retardation and genetic disorders. So like in Russell-Silver syndrome, in patients with something called triple M syndrome, different causes of IUGR can result in or sometimes called small for gestational age. There is difference in the between two terminologies في النيوناتال سيشن اخذتوه، لكن بالنسبه لنا احنا interchanging terminologies here. When we say IUGR or say SGA, it means the same category, that this is a patient who did not catch up at the time of by 2 to 4 years, depending on whether you are following American or British school. So they can be non-syndromic or can be syndromic. Then systemic disorders, chronic illnesses. So chronic illnesses, especially the renal, chronic renal failure, and the gastrointestinal. So the inflammatory bowel disease or celiac disease malabsorption. But other chronic illnesses like asthma or cardiovascular also can result in stunted growth. Then we have endocrine causes, okay? So these are the causes of short stature. Non-pathological, constitutional, familial. Pathological, skeletal dysplasia or chronic illness or IUGR, syndromic, non-syndromic, or endocrine disorders. So this is a difference between the familial and the constitutional. The constitutional catch up, but the familial continue to be short. If we talk about the endocrine causes, there are 4 major ones. These are the growth hormone deficiency, hypothyroidism, so thyroid hormone deficiency, and panhypoparathyroidism. Sorry, pseudo-hypoparathyroidism. That means there is excess of PTH but not working, as I started my talk with. Pseudo-hypoparathyroidism. So excess of PTH but not working at the site, at the target organ. So all of this, so you have 2 of them are deficiency, growth hormone deficiency, thyroid deficiency. Glucocorticoid excess is a Cushing syndrome. In fact, Cushing syndrome results in short stature by early fusion of the growth plates. So this usually have advanced bone age to start with, between maybe 6 or 7, depends on when it appears, until 10, and the child may be taller than his mates. But this child will have closure of growth plate earlier than the others, so he end up short. So glucocorticoid excess, Cushing syndrome, the child can look taller than the others in certain age, but the net result is that the child is short. Then we have pseudo-hypoparathyroidism. They have Albright hereditary osteodystrophy. This is a features, the morphological features are called like this. When they are short, rounded face, and they also have, what do they have in their hand? Common question ده جيبوه دايما في الفوتوز وجيبوه في الquestions.
Dr. Amir, we have one question. This
أيوة.
is Dr. Arwa is asking about what is, just a second.
طيب أشوفه الآن هنا مكتوب ولا في الشات؟
طيب في الشات شيء
ممتاز، جاوبوا كلهم قالوا short, fourth and fifth metacarpal. Very good. This is what they have in pseudo. Excellent. Yes. طيب تفضل قول الquestion.
What is the reliable bone age to say this is constitutional delay?
حاجة أتكلم عنها حسي الآن. أنا حتكلم عن إنه what are the causes of delayed bone age. طيب يعني you don't need to be too detailed لأنه دي very specialized إنك تعرف what degree or what age usually. طبعا the typical course of constitutional delay إنها تحصل between the age of 5 to 9 or 10. فبكون في constitutional delay in this time they notice in the child is short. بعدين they start to catch up around 10 years, 11 years. فبيبقى في approximation of the bone age at this time. قبلها لو عملتها between 5 to 9 delayed. أصلا the causes of delayed bone age are like this. If you have delayed bone age for the sake of MCQs وكده, this is endocrinopathy or constitutional delay of growth and puberty. الباقيين ما فيهم delayed bone age. لكن practically if you have severely يعني affected patient with a chronic illness برضه ممكن يكون زي malabsorbing child will have also delayed bone age. ويعني if you have hypogonadotrophic hypogonadism because you will have delayed bone age. لكن for the sake of exams you need to know إنه the causes of delayed bone age هم constitutional delay of growth on puberty or endocrinopathies. عاوز واحد فيكم يقول لي which one of the endocrinopathies ما associated with delayed bone age. ذكرته أنا الآن. منشنت اشوف في الشات في ناس متابعين كويس. مع الهايبوثايروديزم ابدا. الهايبوثايروديزم معاه ديليد بون ايج. مين اللي قال لك؟ سي اتش مين اللي قال معاه شورت؟ كوشنج اكسلنت اناس تسنيم محمد ممتاز. كوشنج سندروم لانه بيعمل ادفانس بون ايج وبيعمل ايرلي كلوجر. So this is not associated with delayed bone age. ممتاز. Increase cortisol. Excellent. Let us move forward. طيب now if we say this is short ولا لا؟ عرفنا الايج بتاعها. We are going to plot her height in centiles. We'll go the family target potentials بتاعتها مش كده؟ We are going to examine her. She's short and obese ولا short and thin and slim؟ obese مش كده؟ وده بيمشي مع الاندوكراينوباثيز ولا لا؟ يعني انا لو حسي رجعت للكوزز هنا. كويس different causes. افتكر اللي بيكونوا short and obese مين؟ الاندوكراين. طبعا ده اللي عندهم chronic illness بيكونوا عاده short and slim الا يكون عندهم water retention كويس زي renal ولا cardiovascular وات ايفر liver disease. السكليتال ديسبليزيا بيكونوا disproportionate والاي جي ار بيكونوا consistently small كويس. والconstitutional delay of growth and puberty بيكون عندهم pubertal delay. تمام. This is يعني pathognomonic الاشياء دي. فدي اقرب لانه يكون عندها endocrinopathy because she's short and chubby. طيب evaluation of short stature قلنا احنا already according to the causes. انا ما همشي through this كويس لانه you need to map this in your head. Since انه الكوزز اللي احنا قلناها دي معناها انا اصلا لو دار اسال عن الفاميليال والجينيتيك والكونستيتيوشن هسال عن ايش؟ هسال عن انه who else is short in the family. When did they pick up in terms of puberty? Is there anyone who had family delay in puberty in the family ولا لا؟ مش كده؟ ده اسال عن proportionate ولا لا؟ هقول لهم what sort of clothes the top and the lower clothes بتلبس ولا بيلبس عمر كم؟ يقول لك فوق بيلبس كده وتحت بيلبس كده. تمام؟ جيت مثلا لل مثلا chronic illness does he have يعني have any known diagnosis ولا عنده any diarrhea constipation whatever? does he have any renal problems كويس asthma etc any chronic illness. كويس. جيت اسال عن الاي جي ار small progression birth weight. طيب birth weight هو بالنسبه لي اهم شيء. عاوز اسال عن مثلا الاندوكراينوباثيز بسال هل عنده اي يعني other child in the family treated with growth hormone deficient في any history of head trauma حصل. is he wearing glasses or not. see features of hypothyroidism constipation etc. كويس. features of Cushing syndrome whether he has got he put on weight suddenly ولا لا. does he have any tetany etc. this is for the pseudo hypoparathyroidism. كذلك evaluation and for any systemic illness for any exogenous administration of steroids that can give Cushing. كويس. psychosocial milieu يعني it has got any psychosocial distresses that can result in failure to thrive and height is part of that. Neurologic symptoms, visual or headache, so indicates any tumor or anything affecting the pituitary. كويس. ودي كلها في الهيستوري. examination the growth parameters كلها والarm span, so you need to know whether this patient is proportionate or not. طبعا ممكن يكون عنده short arm span ولا lengthy one like المارفان في التول stature وممكن يكون عنده يعني rhizomيليا as in achondroplasia hypochondroplasia. ممكن يكون عنده يعني lower body segment if there is disproportionate because he's got lordotic posture, he has got any scoliosis, etc. He has pigmentation in the skin, maybe part of neurofibromatosis, etc. Nutritional status of the patient for celiac, etc. Dysmorphic features, Turner staging. So if she's a girl, she has got any features of Turner syndrome. The puberty is important. Because if there is delayed puberty, going with constitution, etc., neurological examination and fundal examination, as well as assessment of the thyroid gland. So this is how we mentioned the target height for child and mid-parental height measurement. Sometimes this is described in inches. So you need to be familiar as well of how much the inch is per centimeter. Type baseline investigations for short stature. Well, short stature is a lengthy topic. Others will go quicker شوية. لكن one of the challenging ones. Baseline investigations. طيب أسهل عليكم. دقيقة نشوف في هنا chat and question. The CH causes advanced bone age. حنجي نتكلم عن CH يعني احنا كويس انت يعني في رايكم CH ممكن ولا لا؟ سحر. If you don't know, you ask the question, maybe assuming that you don't know. يعني هو انت الان الاندروجينز كويس ممكن yes. الاندروجينز كويس androgens cause advanced bone age but to certain limit. عشان كده البيشنتس اللي عندهم pseudo puberty they do have some advanced bone age. But يعني this usually will not affect the final adult height. لكن احنا البون ايج ده الان خلينا نخطه في الكاتيجوري بتاعته. In terms of short stature, you need to know انه the causes of delayed bone age are endocrinopathies with the exception of Cushing and constitutional delay of growth and puberty. These are the most important information. الادفانس بون ايج ده موضوع ثاني يعني ذاته بيسالوكم منه كثير as general pediatricians. طيب I'll come back to this. أنا هخلي الشات ده مفتوح هنا شوية عشان لو في حاجة أشوفها أو بشوفها هنا بيصير. طيب investigations للshort stature you can summarize them as follows. You need function tests for many organs. طيب الfunction tests دي كلها لأنها affecting the growth hormone pathway or affecting the growth. يعني the thyroid مثلا. So you need blood function test. ما في حاجة اسمها blood function test لكن هي شنو؟ full blood count ESR for the malabsorption كويس of celiac. You need renal function test لأنه chronic renal failure one of the major causes of short stage. You need bone function test لأنه vitamin D والrickets كويس والpseudo hypoparathyroidism كويس دي causes. You need thyroid function test because thyroid affects the growth. You need liver function test لأنه liver function test in the pathway of the growth hormone. This is how the IGF-1 is produced. So now blood function test, renal function test, thyroid function test, liver function test, kidney function test. And then in addition to that, in any girl, you need the karyotype because there is a spectrum of presentations for Turner syndrome. And you need to rule out celiac disease, so you need celiac screening, and the ferritin is part of that. You don't need the skeletal survey as a routine if the patient is not dysmorphic or looking as having striking dysplasia. So this is required for skeletal dysplasia. The bone age is complementary because it tells you whether it's delayed or not, and it's delayed in constitutional delay and endocrinopathies. Further investigations, level of IGF-1 and IGF-PP3, the binding protein. This is a bit detailed knowledge. You don't need to bother yourself with that. There is also provocation, growth hormone stimulation test or dynamic test. And this tells you about the response of the potential response, growth hormone secretory potentials in the body of the child of interest. طيب دي بس صور عشان تديكم فكرة كويس. الآن this is the mother and this is the child. So this is the mother with growth hormone deficiency. Very severe. This is what? Small for gestational age. So it may have potential catch up by the age of 2 or 4 or not, and it may be a candidate for growth hormone later. This is a patient with malabsorption. ليش؟ لأنه if you look carefully, you will see that إنه الصور بتاعتي دي عاملة شوية هنا. كويس إنه he's not fully pubertal, he's 15, so he's got delayed puberty and also demaciated, and also he has got a falling of height. So this patient has got a defective growth in weight and height and puberty, and this is part of inflammatory bowel disease. This is Turner syndrome, classic features, of webbed neck, shield chest, so the nipples are distant from each other, and then you have low hairline, and you have the features of increased carrying angle. You will have, what do you have in the heart? What do Turner patients have in the heart and Noonan have? Noonan syndrome patients have what? And Turner patients have what?
They are answering coarctation.
Coarctation. So good. So left-sided lesions are in the Turner syndrome. Right-sided lesions in Noonan syndrome. So if they give you pulmonary valve or pulmonary artery, peripheral pulmonary artery stenosis,
they are answering pulmonary stenosis in Noonan.
ممتاز. Excellent. Excellent. So خلاص, this is a golden rule انه right side lesions مع نونان والleft مع تيرنر. I'm just checking on the progress of the course يا دكتور محمد.
تمام دكتور تمام.
كويس. طيب النونان سيندروم طبعا واضح انه بيكون عندهم ايش؟ طبعا برضه التيرنر سيندروم ده واحده من الاشياء المهمه انهم prone to develop what؟ يعني لو جاب لكم في MCQs وكده. تيرنر they usually have infertility لانهم عندهم primary gonadal failure. They have streaky ovaries. They are prone to develop diabetes, celiac وثايرويد. تمام؟ also Down syndrome is similar to them. Also prone to develop diabetes, thyroid, and celiac. So this is required in their screening. تمام؟ طبعا Turner syndrome is what? Is a chromosomal problem. It's an XO. مش كده؟ X0. Noonan syndrome is what? It's an autosomal dominant problem. Can affect the bones. It has certain gene. تمام؟ they are similar في features انهم عندهم wet neck, they have heart lesions, they are short, yes, but the pathophysiology is different. They do have drooping eyelids like this. Okay. So this one is stunted, very short, usually with growth hormone resistance, Laron syndrome. Okay, I'll move forward. طيب FDA approved indications for hormone therapy طويلة, لسه طويلة. You need to remember from them 4. Growth hormone deficiency, IUGR or SGA, chronic renal failure, and Turner. في rare condition اسمها SHOX gene deficiency اللي هي دي واحدة of the dysplasias very similar to Turner, has got specific features. في حاجة اسمها Madelung deformity. You don't need to bother yourself with that. Noonan is also additional indication idiopathic short stature, but approved universally هم الفور ديل الأوائل. كويس. Idiopathic if we don't find a real cause, لكن the patient is short. Prader-Willi syndrome is indication in some countries. It's very useful, لكن it's not given for mainly 30% are growth hormone deficient. لكن they all need it because it improves the body composition. The growth hormone reduces the fat component and increases the muscle and bone. عشان كده مرات الاثليتس لما يقدروا يغشوا مثلا في الكومبيتيشنز تلقاهم مرات they inject growth hormone, بيعملوا لهم تيست عشان يشوفوهم هم they are having artificial boosts ولا لا. ومرات some people برضه misuse it من الادolescents عشان يقووا المسلز بتاعتهم، تلقاهم بيشتروا growth hormone and injected locally in the muscle to improve their muscle build. والبرادر ويلي عندهم بيكونوا جسمهم بيكون تعبان هفتان كده لانه عندهم fatty tissue كثير، this will improve their body build. لكن it was associated with some suffocation and
Recording in progress.
Constitutional acceleration, not delay. This is wrongly written. Or accelerated bone age, then this can be with obese and or non-obese. If it's with obese, then this is exogenous obesity, or we call it simple obesity. And if in non-obese patient, this can be growth hormone excess. If the patient puberty is fine, if it's advanced, this can be associated with hyperthyroidism. طيب سؤال عشان نشوفكم متابعين ولا لا. خلاص, this is the end of growth. In which of the following conditions is bone age consistent with chronological age, not delayed? ثلاثة familial, very good. قلنا severe dwarfism وchronic illness كويس. الجلوكوكورتيكويد excess كويس لكن ما نورمال صح، ما consistent. يعني اللي جاوب 4 ما صح لأنه هو ما delayed لكنه هو ما نورمال advanced، مش كده؟ advanced. اللي جاوب صحيح 3. You're right, excellent. طيب واحد جاوب دي. The 6-year-old girl short stature growth chart reveals the birth length at 60th percentile 6 years and a current طبعا ما في 60th percentile لكن المهم هو في النهاية between the 50th and 75th and the current height at 5th centile. يعني ايش ده هسي؟ length 60th وشويس والcurrent height 5th. يعني في البداية كان كويس مش كده؟ بعدين بقى short. الجروث velocity in the last 3 years has been 3 centimeters per year. Normal ده 3 centimeters per year ما normal. قلنا 4 to 8 مش كده ولا 4 to 7 ده suboptimal مش كده. وال3 بالذات لا 25 اللايت velocity المفروض تكون كثيره جدا. معناها البيشنت ده lost a lot of potentials. السبيرتا كان ممكن تحصل infantile period ما حصلت. her weight at the 50th دي كيف دي؟ short and obese ولا short and slim ولا normal consistently small؟ consistently small ده الاس جي اي. short and obese endocrinopathy. short and slim ده مع chronic illness. تذكروها؟ طيب there are no midline defects or dysmorphism. her bone age is 4 years. اي bone age عشان نعرفه delayed ولا ما delayed العمر إذا هو 2 years and more ده delayed. كويس؟ ب 2 years. less than 2 years معناه ما delayed. كويس؟ acceptable. The bone age compared to chronological. هذه عمرها 6 والبون age 6 sorry 4. معناه what is the most likely diagnosis؟ في delayed bone age. اختلفتم اختلافا كبيرا. كويس؟ طيب الحاجة الاجينست الكونجنتال هايبوثايروديزم شنو؟ الويت؟ لا الويت ما اجينست. اوبيسيتي لما اصلا كلهم هم البوني الانتليجنس فيري جود اللي هو اي او ايفري ون قال الانتليجنس فيري جود وسيف برضه سيدي ممتاز كويس. النورمال انتلكشوال فيري جود برضه يا خنساء وزميلات ممتاز فيري جود كويس. الانتليجنس نورمال انتليجنس this is against congenital hypothyroidism. كرونز والباقيين زي ما قلت لك انا اهم شيء اللي عندهم delayed bone age for the sake of the exam هم الكونستيتيوشنال ديلي والاندوكراينوباثيس. Good. طيب we'll move forward ولا في question في البروس؟ Is that useful to you ولا too advanced الكلام ده؟
They are asking about the answer of the previous question.
The previous growth hormone number 3 growth hormone deficiency.
أيوة. Okay, they are saying very useful.
Very useful, thank you. أنا شايفين ال contribution بتاعه ممتاز.